Today on Substance Stories, we're going to be talking about self-medication and addiction, what people mean by it, and how we should make sense of this. Often people will come to me and they'll say, I use as a way of self-medicating. And that's what I want to talk about today. I want to talk about this idea of self-medicating and how it differs to how I understand, and I think sort of modern psychiatry understands addiction. So we've talked in a previous podcast or video about where we think addiction comes from, and that is that idea that when we have an addiction, we are not doing something to have a good time, but we're doing something to not have a bad time. So it's a form of escape. It's a way of relieving distress, and I think that's really important because it notes that there is distress there to alleviate, right? And that distress might be addiction, it might be an attachment disorder, it might be physical pain, it might be insomnia, it might be the world not being how we think it should be. That is different to self-medicating. And my feeling is when someone tells me that they do an addictive behavior to self-medicate, that's what they're trying to communicate to me. They're trying to communicate that they're doing it to escape the distress they're having. But when in the scientific literature, when doctors talk about self-medicating, what they're really talking about is, say, using a drug to relieve something that it is directly treated. So the two big examples are using a stimulant for ADHD and using a benzodiazepine for anxiety. And I want to talk about why I'm very suspicious about both of them, especially the second one. So why something is an addictive behavior is because it's a maladaptive coping mechanism. By maladaptive coping mechanism, I mean it helps at the start and it makes everything worse at the end. So it actually is counterproductive. And so if I'm engaged, or often people will say that they're using cannabis as a way of self-medicating their psychotic symptoms, but that one is on the face level wrong, because actually when we do double-blind studies, cannabis makes psychotic symptoms worse. So using it, so there's no way it can be a self-medicating. It can be a temporary relief, but it's going to make everything worse. Self-medicating with benzodiazepines is also tricky because when we take benzodiazepines, our anxiety does get less bad. In fact, they're immediate acting medications that make our anxiety less severe. The problem is if we take benzodiazepines daily for more than a month, we're tolerant, and any sort of anti-anxiety or anxiolytic effects it's having are just relieving the tolerance that we've gained to it. We're going through benzodiazepine withdrawal, and then we're getting anxious, and then we're having benzodiazepines to relieve that. And then even worse, after 3 months of daily high-dose benzodiazepine use, we get a thing called bind, which is benzodiazepine-induced neurological dysfunction. And one of the main symptoms of bind is anxiety. So it's making our anxiety worse. So that's what I say to someone when I'm explaining to them why I don't think it's a good idea to be on benzodiazepines to treat their anxiety in the long term, is because overall, you'll get more anxious. And that's obviously what someone with an anxiety disorder is trying to avoid. The same can be said for opioids and pain. So the real problem with the opioid epidemic in the 2000s and was that over time people's pain got worse. So opioid-induced hyperalgesia is this concept where essentially our brain is always recreating the outside world. We don't have a little man in a box, but we recreate the outside world inside our head. And if our pain receptors, our opioid receptors are getting hammered, the body will just say, well, this must be neutral pain. This level of no pain and high opioid receptors must be neutral pain. It'll redefine that as the neutral, and then we'll be in pain with any stimulus. So it's opioid-induced hyperalgesia. And that's why self-medicating pain with opioids like an opioid addiction doesn't work as well. And then the other example I brought up, and this one is a bit more interesting because we don't know at this stage what will happen, is the stimulants for ADHD. And so I think there's a couple of things I want to provide as a background here. with the benzodiazepines, and in the 50s and 60s, there was a huge benzodiazepine epidemic. There's even a Rolling Stone song, Mother's Little Helper, that was exactly about the benzodiazepine epidemic in the 50s and 60s. In fact, the first, what we call minor tranquilizer, wasn't quite a benzodiazepine, meclobamide, which was called Milltown, was so popular in the US in the 50s that you could buy it in cocktails. They would make a martini and drop a Milltown, and they would sell it as a Milltini. So it was this huge cultural phenomenon. And then, of course, people got addicted and their anxiety got worse. And then we had the benzo sort of epidemic and Mother's Little Helper. And we did a lot to try and calm down prescribing of benzodiazepines because they were making everything worse. And then everything repeated itself in the early 2000s, late 90s, early 2000s, where they were prescribing opioids in en masse, and we had the opioid epidemic and all the deaths entailed between that, and everyone's pain got worse, right? So the two things about what we can take about these drugs is they're immediate acting. If I take a benzodiazepine and I'm anxious, I'm no longer anxious 20 minutes later. And people build tolerance, and over time, they make our thing worse. It's the same as through opioids. Or if I take opioids for long enough, my pain's going to get worse. If I take benzodiazepines for long enough, my pain's going to get worse. Now, is that the case for stimulants? Is the interesting question. Well, we don't know. We're certainly if we look back on the benzodiazepine epidemic and the opioid epidemic, we can certainly say that over the last few years, there's been a massive increase in the amount of stimulant prescribing. And that's secondary to essentially what we define as ADHD being broadened, and what we would look for in terms of the dysfunction caused by ADHD to be loosened. So previously, if someone had a job and gone through university, there was no, with untreated ADHD, the guidelines would have suggested there's no way they could have ADHD because it was about dysfunction, where that seems to have been loosened in a lot of cases. That's a very controversial area. But could someone with stimulant use disorder be self-medicating their untreated ADHD? Well, this is a tricky one. Very possibly they could be. We don't know. I think it's important to keep in mind that the illicit stimulants that people are buying are much, much, much stronger in dose than ADHD medications by a factor of about 100. So this is not the same amount of medication that someone's having. The other thing is it's very possible that illicit stimulant use is somehow changing altering the amount of receptors in the brain, meaning that someone that uses illicit stimulants is going to have lifelong cognitive difficulties, concentration difficulties, so that could be possibly making ADHD. But the skeptical addiction specialist out there might say, well, if we look at this epidemic, or the current rates of stimulant prescribing, it is very similar to previously. In the 60s, we were treating, what Betty Friedan referred to as the feminine mystique. We were treating sort of angst and existential angst due to societal inequalities with a medication that was making everything worse. In the 2000s, we were treating basically the same thing. We were treating unemployment and long-term chronic pain with opioids, and perhaps now we are treating the fact that we all carry around these little distraction machines called mobile phones, the demands of the 50, 60, 70, 80, 90-hour work week with stimulants, and they're very concerned that we might look back on this in 10 years' time and say, my goodness, we've created a third epidemic of a drug of abuse. Because stimulant medications, they are immediately acting. You absolutely do build tolerance to them. I don't know. I've certainly in my clinical practice met a lot of people that have benefited greatly from stimulant therapy. It's really helped them, and I think that's absolutely terrific. And there are a lot of people that have in the past had stimulant use disorders and have been later diagnosed with ADHD, and again, very much benefited. The evidence as to whether diagnosing someone with with ADHD does reduce their substance use is controversial. Depends on which meta-analysis you're reading as to whether it does help them reduce their stimulant use. But it's an interesting one. So I think, like with all these things, what I do is I try to have these conversations with my patients in the room, and we talk about them together. We make our decisions together, and I think that's what we need to do with all this stuff. So with self-medicating, I think that when people use it in today's parlance, when I'm talking to most patients, that what they're saying is, it's the same thing that I'm explaining. It's the escapism of substance use rather than actual direct treatment of an illness. But the one part of my practice that I do see people talking about self-medicating is stimulant use, and I think it's possible, but I think we should be realistic about it in terms of the doses we're using in illicit substances are way higher. I think we should take that lesson with how we should use the stimulant use when we're treating ADHD, which is try and take stimulant holidays. Watch for tolerance. Make sure that we are treating the ADHD and not other existential angst, and we're not trying to escape from just being our sober selves. Because as I always say, there is nothing wrong with being our sober selves. In fact, I think the best thing that we can, the best part of life is enjoyed sober. So a brief one today. Thank you so much for watching or listening. I just want to add in the end that we are really interested in doing a couple of episodes with all your questions getting answered. So please email in your questions to learn@meducate.com.au. That is learn, LEARN, at little @ Meducate, MEDUCATE.com.au. I really look forward to reading your questions and answering them. Thank you for listening.